it will get better. There's something about being able to tell another human being that I did this, and I can't believe I did. I can't believe I hurt my family like that. I can't believe I said that to my child. I can't believe I said that to my wife or my husband. In here, we've all done that. We've all been there. We've all been there. And what I'm here to tell you is that with recovery, families are healed.
Most of our staff are truly embraced in recovery. A lot of them went through Willing Way. A lot of them are living proof of the 12 steps and Alcoholics Anonymous or Narcotics Anonymous. So they get to see people living their life and living a really active and fruitful life and then giving back.
Most important lessons that we promote, which are also lessons that Alcoholics Anonymous promotes, are that we need to stay connected. We need to stay connected to each other, and when we go off on our own and making decisions without running things by people or seeking advice or support, then we're usually headed in the wrong direction. So the largest lesson that we promote here and that I think I learned in my treatment as a patient here was to stay connected and to run things by people.
It's not a comfortable setting to be in, let's be honest. Like, you have to wake up early some days, you may have to volunteer at the soup kitchen, you may have to ride your bike across town when it's 40 degrees outside, and they don't like that. And I didn't like that when I had to do it. But there's something that happens when you go through that together. There's a trust. I mean, the people I went through with, that I experienced that with, I would, if they called me right now, I would walk out of this interview and I would go and help them with whatever they needed.
That's probably the biggest part of this deal, is that it's not me telling you what you need to do or anybody else. It's you telling me what you want to do and me figuring out a way to help you do that. That's the thing that I found at Willing Way that is a little bit different than other places. And I have seen that in my own recovery. When I came in, we worked on the problems that I wanted to work on.
People come in here and their eyes are dull and dead. There's a dullness to them. And as a counselor over the years, I have seen the spark come back and the life come back. And I asked a counselor many years ago when I first started in the business, what am I seeing? I said, I see this light in their eyes. And he told me their soul is returning. And I've held on to that ever since.
I didn't have anything when I came here. I came in with a bathing suit, a hoodie, my driver's license, and I had shoes with no shoelaces on. And I didn't have anything else.
Our patient counselors can empathize with what it's like to be in their seat, to be in these rooms, in these groups. So yeah, I can sympathize with a lot of people and a lot of things, but I think empathy is one of the things that just saturates throughout our staff, particularly our clinical staff. It's going to be hard to find someone that works here that has not been in someone's shoes that comes through here, either as a family member or a patient.
It's been extremely rewarding for me personally because I walked in their shoes.
When you get a call that someone's saying, I just got my 1-year chip, thank you. You know, I get emails that, you know, I've been sober for 15 years or, you know, that's success. That means that, you know, we did everything that we could and gave them the best chance somewhere safe for them to get sober.
Basically what it boils down to, the drug addict and alcoholic that I am, if I can do this and showed up with nothing, you can. Because it was bad.
If I see those amazing results and those happy faces, it is because they've done exactly what we've encouraged them to do, follow the recommendations. So we don't just give recommendations to the patients, we give them to the families too, and it works.
It's nothing like it. It's just nothing like it. Nothing.
Kick off our last speaker for the morning portion before lunch. So I would like to welcome Cate Faulkner to the stage. She currently serves as a program manager for the Tennessee Department of Mental Health and Substance Abuse Services, overseeing the Regional Overdose Prevention Specialist and Harm Reduction Program. In this role, she oversees Tennessee's largest harm reduction program, including training, education, and naloxone distribution. Now, prior to working for the state of Tennessee, Cate worked in community services in Arkansas, Chicago, and Nashville, including youth violence prevention, community health, and family support. She holds a Bachelor's of Arts degree in International Studies from Georgia Southern University and a Master's of Arts in Social Services Administration from the University of Chicago. I will not hold that against you. I'm a Northwestern grad, but she maintains her license as a clinical social worker currently. Let's welcome Cate to the stage.
Hello, I'm so happy to be here. Apparently my computer has decided that it was gonna go to sleep, so I'm gonna log back in while we talk, but I am very excited to be here with you all. I have the pleasure of working with the Memphis Area Prevention Coalition, who has several grants through our office, including the Regional Overdose Prevention Specialist, who I hope you have all met, and if you haven't, today is your day to do that, please do that. Let me see. Technology. Okay, we are rocking and rolling. So I know this is the last session before lunch. I would probably be getting drowsy if I were you too. So hopefully we're gonna make this a little more interactive, a little bit more ways for you to all to participate and then get you off to lunch. So today I'm gonna be talking about overdose prevention and harm reduction. So we'll talk about what it is, how it happens, and why it works. There's a lot of evidence for that. So today we're gonna get started with a little Menti survey. So pull out your phones. Everyone's got them out already, it's fine. Go ahead and pull them out and go to, oh no, where did it go? Okay, my survey is not working, so I'm going to do a show of hands today. Who is here as a student? Awesome, that's great. I love that you all are spending your Friday doing this. Who works in substance use treatment, recovery, and or harm reduction services? Okay, some folks there. Any mental health providers? Okay, got some of those too. Social services, community service, community resources. Okay, a couple there. Any law enforcement and first responders? Okay, not today. Anyone from public health? Okay, one or two. Education? Okay, a couple others. Something I haven't named so far. Okay, what else we got in the audience here? Healthcare, excellent. Oh, I thought I had medical in there. Anyone else working in medical settings? Couple folks, excellent. Welcome, welcome. Well, I'm so glad to have such a diverse audience. I think that really speaks to the opioid crisis, the overdose crisis, and the importance of multi-sector engagement in this. So before we get started, I do want to do a quick survey about how familiar people are with harm reduction. So who is very familiar with harm reduction? Okay, excellent. Who knows some about it? Okay, know a little bit about it, have heard of it? Okay, anyone going, what am I here for? It's okay, no shame, this is why you're here to learn. Okay, excellent. So that helps me. So I'm gonna do a couple of slides here to just do some level setting. I want you all to understand where I'm coming from and my basic kind of assumptions that I'm working off of. I'll do these fairly quickly because I think you all have heard a lot from other presenters today. So framing up that addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, environment, and an individual's life experiences. So starting with that, I think you've heard a lot today about people coming from that framework. That is, in fact, the definition from the American Society of Addiction Medicine. Today, I want you to keep in mind the continuum of substance use. So what this looks like is there are folks that are completely abstinent from substance use. There are also people that have full-blown addiction and or meet the clinical criteria for a substance use disorder. And guess what? There's a lot of use in between those two things. And so when you see this, there are lots of different ways this gets illustrated. People that are using medications like opioids as prescribed. Then there are other things, people who use casually or recreationally. And then you see that kind of going down that road. For some people, that progression towards addiction or substance use disorder is quick. For others, that may go on for years. And for others, they may never reach those full-blown addiction or substance use disorder criteria. Another point I want to hit on is this recurrence. So lots of people talk about this in terms of relapse. We choose to use the language around recurrence as a reduction of stigma. And so what is that? It's a chemical response in the brain. It is not a moral failure. It's not a failure of treatment. It is a part of many people's recovery journeys. 40 to 60% of people in recovery will have a reoccurrence. And we need to make sure that that is not a shaming experience, that that is a part of the journey, and it's an opportunity for people to develop skills, utilize skills, go back to the basics, figure out what they're missing, and fill those gaps in. So in case you're wondering about, well, why do we talk about that differently than something else? Consider high blood pressure. So 50 to 70% of people who have high blood pressure require yearly medical attention. So this idea that that substance use is a very different thing than other medical conditions, certainly it has its different qualities, but we talk about these very differently. So last thing I want to talk a little bit in terms of level setting is about trauma and adverse childhood experiences. If you're not familiar with these, I encourage you to read more, take a training about that. And so it comes out of a study that looked at the long-term health outcomes related to early experiences. So what I want you to know about that, ACEs are common. 6 out of 10 adults have one. 1 out of 8 US adults have 4 or more. What we're focusing on today is that they do in fact increase vulnerability to lifetime health outcomes. Things like mental health issues, things like heart disease and diabetes, as well as substance use. So 5 or more ACEs, 7 to 10 times more likely to use illicit substances, 6 or more, 46 times more likely to inject substances. So these are, again, ways that we think about how someone ends up where they are and how do we think holistically about an individual that's seeking out treatment. So level set there, I want to talk a little bit about stigma and how that plays out. So I was a clinical social worker before I took this job at the state. I have written lots and lots of case notes. I assume some of you all in this room also have. So I want to read this one here. So, patient failed their drug test for the 3rd time. Patient is non-compliant with treatment regimen to abstain from drugs. Patient refuses to stay clean. Patient was told if they had another dirty drug screen, they would be dismissed from the program. Who has written or seen a note similar to this before? That's pretty common. That's pretty common. Let me turn the tables a little bit. Let's look about that same language about diabetes. Patient failed their A1C test for the 3rd time. Patient is non-compliant with the treatment regimen to eat only healthy foods and exercise daily. Patient refuses to manage their diabetes. And patient was told that if they had another high A1C, they would be dismissed from this doctor's care. Who's seen a note like that? Right. Maybe some of that's in there, but very rarely do we talk about other chronic medical conditions the way we talk about substance use disorder. Why is that? We have a whole lot of assumptions, a whole lot of stigma about substance use that doesn't seem to align with the way we talk about any other chronic medical condition. So we do it side by side. We talk about failure. Who talks about failure in terms of an A1C test? We don't. We talk about high, low, medium. We talk about treatment regimens, only eating healthy food and exercising daily. Is that an expectation that your doctor would likely have for you to do or be dismissed from care? No. Refusing to manage your chronic condition. I sure hope my doctor isn't writing those things about me. And certainly, those would not be grounds for dismissal. So, keeping that in mind, let's talk about stigma. So when a person experiences stigma, they are seen as less than because of their real or perceived health status. So that comes from NIDA. Here's some what the research says about that. Experiencing stigma can reduce a person's willingness to seek out help, take other actions to reduce harm, and or ask for help. Stigma among medical and social services reduces the quality of care. And even the language that providers use internally and externally with clients impacts that. Delaying treatment can cause additional harm to an individual. So one study shows that one stigmatizing interaction with a medical provider delays seeking out help 5 to 6 years. 5 to 6 years. And what does that mean in the age of fentanyl? That really can mean the difference between life and death. That is how serious stigma is. So what do we do about that? So I'm going to talk a little bit about, there's a lot to unpack here. It is one of those things that's on a continuum. We all have to keep learning. I know as a provider who is steeped in abstinence-based treatment settings, I had a lot of stigma that was wrapped up in that language and wrapped up in those systems. And when I started learning more about the stigma reduction, I had to do a lot of internal work to unpack everything that I had learned there. So if you have used this language before, if you have written a case note like that, today is the beginning of a new start, and that's okay. So some easy ways that we can start doing that. Let's talk about doing away with labels and using person-first language. So we'll talk about people with a substance use disorder, or people who use drugs, or people who inject drugs. We don't talk about addicts. We talk about a person first. Some other ways that shows up commonly, a person with a substance use disorder, positive or negative toxicology, sterile or used needles. So what I will say is, having worked as a provider and working with other folks, the language around clean and dirty is one of the hardest ones to switch. But it is so important because an individual is not clean or dirty. Those are the behaviors. Those are the results of a test. We'll also talk about not using substances, and then also things like people living in recovery, not an ex-addict. So again, we're talking about people and we're talking about behaviors. We're not talking about everything about a person wrapped up in one label. So if you're interested in some more, there's a lot out there. There are 2 resources that I would recommend. The In the Syndemic Project, Tennessee, is facilitated through the Tennessee Department of Health and includes language resources not just on substance use, but HIV, STIs, viral hepatitis, and some other great resources. So that's a local resource. Also, the National Institute on Drug Abuse has some great resources as well. If you search NIDA and Words Matter, you'll come up with a list of articles. There's some language guides there and a free CME or CE module. So also a great resource there. So I'm going to transition over to some discussion around harm reduction. So by show of hands, who has heard of harm reduction before? Help me remember. Okay. So lots of folks in this room. So I'll start with this. For no other medical condition would we start with the most extreme option. So abstinence only. What makes us think that this would work for a condition as complex as addiction? So I would highly recommend this TED Talk. It's a great overview with Dr. Mark Tyndall. It's called the Harm Reduction Model of Drug Addiction Treatment. It's a great primer. It's one of the first things I started learning about when I started this work. So what is harm reduction? So today I gave you 3 definitions. I had about 10 more that I found. So there's a lot of discussion about this out there. There are a lot of people who have their ideas of what this looks like. So I pulled 2 from the federal government. So SAMHSA talks about engaging directly with people who use drugs to prevent overdose and infectious disease, focuses on physical, mental, and social well-being of those served, and offering low threshold options to treatment and healthcare. So that's a pretty holistic model. That's not just, hey, here's a clean needle, a sterile needle. This is a holistic approach. The Health and Human Services Office talks about meeting people where they are without judgment, stigma, and discrimination. So we shorthand in our department talk about harm reduction as a way of preventing disease and promoting health that meets people where they are. That's the key part, meeting people where they are. We're not expecting them to come to us. We're not expecting them to come in a more put together way than they are. We're asking them to come as they are, where they are. And where does that come from? It really comes out of this idea that not everyone is ready or able to stop substance use. And so there are scientifically proven or evidence-based practices that decrease risk, and we need to embrace those. So a couple core principles. So we're always thinking about a non-judgmental approach that focuses on enhancing our quality of life. We recognize that behavioral change is an incremental process. Who has gone from no exercise to running a 5K in one day? Anyone? No. In that way, we embrace an incremental change. I'm real happy if I eat like 3 salads a week. That feels like a win to me. That's an incremental change approach. We also have to acknowledge that social factors increase the vulnerability. So things like poverty, social inequality, trauma. Our presenter this morning talked about those social determinants of health. That's what this is here. And then the last one, we really want to make sure that people are empowered to be the primary agents. This is not about what I think. This is not about what your clinician thinks or what your mama thinks. This is about the person who is living in that body, living in that space, being the one to drive that and to win when success happens. So I want to go back to this case note we wrote before. So you see the on the left side, the one we talked about, and then let me think about how can we rewrite this using harm reduction lens. So as you're looking at this, you may be in an agency that does not necessarily embrace ongoing substance use as a part of treatment or a part of medical engagement. That's okay. There's still ways to do this. So this one says, drug screen shows recent opioid use. Patient reports reducing use from 10 times to 8 times a day. Patient is participating in regular counseling session, provide an information packet, and discuss HIV prevention. So how do those principles show up? Do we see language like failure, non-compliance, refusal, abstaining? In this one, those are all words that are judgment laden. Those are ones that there's a lot of judgment. And so how do we take notes that report behaviors? So drug screen shows recent opioid use. That's not a dirty screen. That's not a failure. That's reporting what that drug screen showed. We talk about focusing on a quality of life. So this individual has made some improvements in their life. They're using less. They're participating in counseling sessions. Those are steps towards a better quality of life. We talk about incremental change from 10 times to 8. I would also add that I think participating in mental health care, that's also an incremental change. That is also a key to an overall better quality of life. Empowering individuals. So we haven't kicked them out. We're still engaging in treatment. And things like providing information and discussing HIV prevention. That's also empowering an individual to use the information that they have and decide to make a choice that takes care of themselves and the people around them. And lastly, things that reduce harm. So using less, thinking about HIV, moving towards those preventative steps. Those are all ways that we can think about how do these principles show up in the work that we do with clients. Okay, so that's kind of an overview. So I want to spend the rest of our session today talking about how is harm reduction being done in the state of Tennessee. So for each of these, I'm going to show some of the main strategies. I'll provide a little bit of context for why those are important. I'll give an overview of the strategy, and then I want to close out with some of the evidence and key points. Because remember, I told you we use evidence-based practice. So I'll start off with this quote. This was done at the International Overdose Awareness Day press conference at the Tennessee Bureau of Investigation. This man that you see there is Director David Rausch. He is the director, the head honcho at the Tennessee Bureau of Investigation. And look at what he's saying. He said, there are harm reduction strategies that have great evidence behind them, and those are the ones that we are consistently talking about and looking to how to implement with guardrails in Tennessee to protect our citizenry. So what you're seeing is this is not just a mental health perspective. This is not just a treatment recovery perspective. This is our top law enforcement for the state who is saying, hey, you know what? We're not arresting our way out of this problem. there have got to be other strategies. So what drives the work that we do in Tennessee around harm reduction? As I said, we utilize evidence-based practice. We provide education and information on a wide range of topics and settings, from primary prevention to overdose prevention. We recognize and support that there are many different paths to recovery. Each person is on their own journey and they need to find the tools that work for them. We work on providing tools that reduce negative consequences, and then we're seeking out opportunities to connect to resources and things like care coordination, patient navigation, things like that. So the 5 strategies I'm going to talk about today: training, outreach, and education. You've already heard a lot from Tony Jackson about that. I'll do that briefly. MAT and MOUD, those you also heard about during the first session. And then I'll spend some time talking about fentanyl test strips, naloxone distribution, and syringe service programs, which are operated through the Department of Health. So training and education. Overdose prevention and awareness training. If you have not done a training with the regional overdose prevention specialist, this is my shameless plug to go tell you to go sign up, because that's one of the key strategies we talk about. Brief naloxone trainings. You might have heard people talk about this as Narcan. Narcan's the brand name. We as a state do not endorse a single product. There are lots of options out there, so you'll hear me use naloxone, but you probably know it by Narcan. So that happens through our ropes. That also happens through syringe service programs and other community agencies. We also offer specialty training and resources. I think you heard some about the work that Dr. Brian Windbigler is doing with fentanyl and stimulants, and then community outreach of all types. So that's happening through our overdose prevention programs. That also happens through primary prevention and the coalition. That's also happening by a variety of agencies that are out here. So these are not limited to just what is funded through our department. So next strategy I'm going to talk about briefly, since I think you all heard about that this morning, is medication-assisted treatment or medication for opioid use disorder. Things like buprenorphine, methadone, Suboxone, Vivitrol, Sublocade, things like that. The emphasis here I've underlined is this medication-assisted treatment. So those work best when they're combined with behavioral supports, things like mental health care, community supports, other things like that. You heard this morning, it's really about normalizing brain chemistry. And what that allows is that part of someone's brain to not be the one screaming. And in that, people can start to work on some of those other recovery capital, those skills, those connections, those relationships that are going to sustain them over the long term. Also focusing on, this is a medically proven tool that supports and sustains recovery. For some folks, that's a short term, and for some people, that's a long term, and both are evidence-based. And this is a widely understood tool to be important. So you can see a list of folks there that have said, hey, no, this is worth doing. So this is very similar to what you saw earlier. There are a lot of good outcomes for patients. Survival, that's a great outcome for someone. But also people's length in treatment, their ability to gain employment, maintain employment, and especially for pregnant women or pregnant people with substance use disorder, better outcomes for them and for their babies using things like MAT and MOUD. A decrease in the use of illicit substances, criminal activities, reducing the risk of contracting infectious diseases like HIV and viral hepatitis, and then reducing the risk or the vulnerability to recurrence. So some pretty good outcomes. You're frozen. There. Okay, the other thing I wanted to really pull and highlight for you is that one of the strengths of MAT and MOUD is that holistic approach. When we take a holistic approach to an individual, there's a holistic healing, and that happens over the long term. You'll see another study that looks at use among rural residents. So you'll see less use in general, improved overall health, fewer symptoms, and some reduced in mental health conditions and symptoms as well. This is not my friend. Okay, so who's heard of fentanyl test strips? Okay, A few folks? Excellent. Okay, so let me give you a little bit of context for this. So what is the cost of opioid use disorder for the state of Tennessee? What's the cost of a fatal overdose in this state? Well, one study looked at $24 million a year. That's what it's costing us. And that includes things like healthcare, substance use treatment, criminal justice involvement, lost productivity, and reduced quality of life. Who thinks that that is where we want to be spending all of our money? No. Guess what? There are ways to prevent that. Quick overview about fentanyl. I think people have talked a little bit about it. It's an extremely potent synthetic opioid. So you can see there, that amount next to the penny for an opioid naive person, that's enough to kill you. You can see the comparison for heroin, fentanyl, and carfentanil. Carfentanil is also a version of fentanyl. It is usually used to tranquilize elephants during veterinary procedures. So that tells you how strong that is. I think you heard this morning about the data. So that's the 2020 data, but although the 2021 data, I think, shows some similar trends. Fentanyl is driving fatal overdoses in this state. And not just among people who identify as opioid users, but also people who identify as stimulant users. So fentanyl is commonly mixed with cocaine, methamphetamine, heroin, benzodiazepines. You'll also notice you don't see marijuana. TBI is not seeing that in what they're testing. So I think that's always a fear and anxiety for people, but that is not a widespread thing we're seeing in in lab reports. You'll see there about kind of that chemical chemistry. So one of the dangers of fentanyl is that when it's mixed in with amateur chemists, they're not distributing it evenly like you would be getting for your prescriptions. And so what ends up happening is some of those pills, some of that powder will have a deadly dose, others would not. And that's why it's so dangerous. So the testing is really the only way. There's no distinct smell, taste, or color to it. So it's pretty serious. It's out there. What do we do about it? So fentanyl test strips are a small strip of paper that can detect the presence of fentanyl and fentanyl analogs in a substance. It became legal earlier this year with the guardrails that Director Roush talked about. So key points on that. If it is found at the site of distribution, they're still considered drug paraphernalia. But to an individual user, they're not drug paraphernalia. The other thing that happened was that TBI required there be a sunset. So in 3 years, there'll be a revisiting of that. And so one of the things that we are working really hard to do here in Tennessee is show that this is a useful tool. And I'll talk a little bit about the data collection in just a minute. They're quick and easy to use. You mix it with water, you dip it in, you let it dry. Pretty quick, pretty easy to do. But the thing that we are really excited about is highly correlated with behavior change. So studies show that when drugs test positive for fentanyl, people change their behavior. They make sure to have naloxone nearby. They're not using alone, they're using with another person who can revive them. They're not using that drug, they're taking it back. They're only using one drug. They're not mixing it with other substances. So one of the early research studies for the Southeast showed that 7 out of 10 people changed their behavior if their test strip shows a positive. In the state of Tennessee, we started doing a pilot with our Search Service program back in July. And we asked, if your test strip shows fentanyl, what do you do? 84% of people changed their behavior. They implemented some kind of harm reduction strategy. That's huge. That is the potential to save lives. Okay, so next thing I'm going to talk about naloxone, or Narcan, as you probably know it. Let's talk about opioid-involved overdoses. So naloxone only works on only works on those mu receptors, which is where those opioids go. So 2020, 3,032 overdose deaths in the state of Tennessee. Of those, more than two thirds, involved opioids. So that means those could have been prevented with naloxone. Now, the two things that I want to highlight here are in 74 cases of those fatal overdoses, there was a bystander present. That meant that someone could have intervened and that person could still be alive. The other thing I want to highlight is that 76% of those are happening in a home or residence. So I think sometimes when we see these really big numbers, we assume like, oh, everybody could encounter an opioid overdose, and it's possible. But when we talk about best practices for naloxone distribution, we're talking about people that are closest to it. These are friends and family members who know that there's substance use going on in the home. So what is naloxone? Super quick version of it. If you haven't taken a ropes training, take a ropes training. It is an overdose reversal medication. What it does is it takes those opioid drugs off of the receptors and allows people to start breathing again. It is not new. It's been used by medical professionals since 1971. In 2015, we got the nasal one, the spray, and that became more widely accessible to the general public, and first responders were a lot more likely to use that than pulling it up out of a vial with a syringe. It is easy to use, restores breathing. It is not addictive, and there is no potential for abuse. So what does the data show about that? Increasing access to naloxone does not increase opioid use or substance use. Some research even shows that people who are educated about naloxone reduce their use. For every dollar spent on naloxone programs, there's a $665 social benefit. For every death avoided, there was a $6,612 benefit. So if those numbers don't encourage you, I'll put it another way. Through this program, since 2017, more than 51,000 Tennesseans have gotten a second chance, or a third chance, or a fourth chance. They're alive because of naloxone. So that's a pretty big thing that we've done here. It's also not enough. We got to keep doing it. Okay, so the last thing I'm going to talk today about is a syringe service program. So my colleague Allison Wilhelm, who is over the syringe service programs through the Department of Health, was not able to be with us today. So I'm going to present these slides, but also want to give her due credit for her work in this. So here's our good friend, Director Roush today. So prior to coming to the TBI central office in Nashville, he was working in Knoxville, and he talks about what it was like when the community came to him and said, hey, we want to do a needle exchange. He said, I was adamantly against it until they gave me the data. And when we looked at the data, we saw the number of hepatitis cases and AIDS cases that dropped as a result of needle exchange, and it made perfect sense. That's our head law enforcement guy right here saying, hey, syringe services, that's something we should be pursuing. So a little bit of data around infectious diseases that are associated with substance use. So the two that are most commonly talked about, HIV and viral hepatitis. So HIV, 13% of people with HIV don't know they have it. 7% of new HIV cases are among people who inject drugs. What's the lifetime cost of treating someone with HIV? $450,000 per person. So I brought in a little bit of Shelby County data for you all today. More than a third of new diagnoses of HIV in the state of Tennessee are right here in Shelby County. 36% of people living with HIV in the state of Tennessee are right here in Shelby County. So what does that mean? It means preventative efforts are so important. Another condition that we talk a lot about is viral hepatitis, which is a liver disease. With unsterile injection equipment, it is 10 times more infectious than HIV. Majority of new cases are among people who inject drugs. Tennessee ranks 7th in the nation for new HCV infections. It's also extremely expensive to treat, $40,000 to $100,000 per person, per infection. So again, value of prevention, huge. So what are syringe service programs? They are proven effective community-based prevention programs that provide a range of services and supports anonymously and confidentially. You all are very fortunate here in Shelby County to have several of them, and that number is growing by the day. What do they offer? Sterile injection equipment, testing for HIV, hepatitis, STIs, and linkages to service, treatment, and care for those conditions. Referrals to substance use treatment, medical and social services, and education and tools for overdose prevention and safer substance use. So here's some common questions around SSPs that I want to make sure we address before I go any further. So they are not supervised injection sites. They do not allow drug use on site. They do not sell or distribute drugs. You cannot use government funds for syringes. Don't worry, your taxpayers are safe. They're not doing that. They do not increase crime in the areas. There are strict rules about where they can be located, so they are not near schools or parks. And they cannot provide only syringes. They have to offer a wide range of services and resources. So let's talk a little bit about a very brief history. So they started as a community response to crises. So we see them in the 1980s in response to the hepatitis B outbreak in Europe. We start to see them in the US in the late 80s, early 90s as a response to the HIV crisis. They were using grassroots organizations before they ever were studied and became evidence-based. So I want to talk a little bit about the Scott County, Indiana outbreak, 2014-2015. The outbreak was among rural residents who injected drugs. Scott County is not a large county, y'all. 215 cases, and of course, a fairly short time frame were linked to that outbreak. It really raised the alarm on the potential for these HIV and HCV outbreaks across the country. So following that, the CDC started doing what they call a vulnerability index. They looked at a variety of factors to figure out where else could that happen. 41 Tennessee counties made that list. So about 20% of the counties that the CDC identified as high risk for another outbreak like that were right here in Tennessee. So what happened next? In 2017, syringe service programs in Tennessee were legalized. Early on, they were non-governmental organizations. They have to be approved through the Department of Health. Recent amendments have allowed them to also operate in county health departments. And then what do they require? So this is what the law says has to be offered. They have to provide needles, syringes, and other injection supplies at no cost. They have to offer disposal. They provide educational materials on a wide range of topics. They have to provide a referral for naloxone. They provide on-site consultations for mental health and addiction treatment. And they provide SSP participants a verification card. So what that means is there is limited immunity for individuals who are stopped going to or from their syringe program, their syringe service program in terms of criminal prosecution. So they've been operating in Tennessee since 2017. I think we're up to 9 or 10 at this point. So let's talk about the impact that they're really having. 54,000 client visits. That's that many people coming over and over again. Individual visits. They have distributed 2.6 million syringes, and they've collected 2.1 million syringes. So those syringes allow for sterile use and reducing the risk of infectious disease transmission. They have distributed this is for all of 2020, 1 year alone, distributed 53,000 naloxone kits, reported over 13,000 overdose reversals. Also offering tests for HIV and HCV tests. So I don't think this is in the presentation, but the positive results on the HCV tests are about 40%. So 40% of people who are using drugs also have HCV. So that's why these sterile injection equipment is so important to reduce the transmission and the spreading of that disease. So if you're wondering, hey, is this a good thing to do or not? Let's look at the research. 50% reduction in HCV and HIV cases. That's huge. We're saving healthcare dollars by preventing infections. And then in terms of substance use, participants in SSPs are 3 times more likely to stop injecting substances than those that don't participate in a syringe service program. People who inject drugs are 5 times more likely to enter treatment when participating in a syringe service program. It's those people that are being met where they are, as they are, and those relationships that people develop through these programs that really make a huge difference here. We talk about reducing overdose deaths through education, naloxone, and other prevention resources. And this is, I think, a huge one. People who use drugs are probably not showing up to a lot of community services and community resources. There's a lot of stigma. We talked about that earlier, medical professionals, but syringe service programs, when done well, are a welcoming place for those people to come, to be serviced, to receive the supports that they need. So oftentimes people are really concerned about the public health benefits of syringe service programs. So what do they do in that room? They reduce needle stick injuries by first responders by providing proper disposal. So if a first responder is patting down a suspect, if they have syringes on them, that's a risk for those first responders. But when they're disposed of properly, that reduces that risk for first responders. People also often assume that the number of syringes in public places is going to increase, and they don't. With syringe service programs, that safe disposal is really important. So when two cities were compared, the one with an SSP had 86% fewer syringes in places like parks and sidewalks. Who wants that in their community? We want those places to be places our children can run and play safe from needles. And then the other piece of that is when more syringes are provided by syringe service programs, the more likely people are to dispose of them properly. And then the last one is no increase in crime has been seen in places with SSPs compared to other ones. So again, lots of public health benefits, lots of public safety benefits to syringe service programs as well. So I'll finish up with a reminder that harm reduction is a way of preventing disease and promoting health that meets people where they are. So as we finish, you think about the last 50 minutes or so you've spent with me. So how familiar are you with harm reduction? Very familiar? Okay, good. You know some about it. Okay, know a little bit about it? Hopefully people are leaving with more information. Anyone feel like they still don't have any idea what harm reduction is at all? Okay, excellent. Well, I hope that this was a helpful understanding for you. This is a topic that is often unfamiliar and sometimes uncomfortable, and that's okay. But I think there are lots of reasons why this is important and lots of ways to engage with that. So I encourage you to think about the ways in which you can be thinking about those strategies, and whether you're taking trainings or participating in events, or even just thinking about your language with your clients. Those are all really important strategies to be using.
We do have time for one or two questions. If anybody has one.
The syringe service programs have been doing those, I think at some scale for a couple of years. They've been receiving them through our grants for the last couple of months. And I think the ropes have also started using those with community distribution in the last couple of weeks. Yes, there are some at the table. I think the other thing I will make sure, she said they're at the table, so you can go visit the ropes. What we encourage is that those go to people who are using illicit drugs. Like, you're not going to be at risk for that with your prescriptions. This is really about illicit use. So just kind of clarifying that. The other thing I'll mention about that is they're much cheaper than a lot of other harm reduction supplies. So if your agency is interested in that, or people you know are interested, we've been using the TN Scientific brand. And those are based right here in Tennessee and are much more sensitive to the analogs in Tennessee. So the ropes are available to provide training and an overview of how those work. Yes, they're not a prescription product. To the best of my knowledge, I haven't even heard of pharmacies giving them out. So right now, I think it's mostly community organizations or individuals that are pursuing them from online. Yes.
How is harm reduction not just enabling addicts to continue using?
We're working on reducing harm, and we recognize that incremental change is really valuable, and that that's a part of the pathway to recovery. I think I'm standing between you and lunch. Thank you all so much. Have a great day.
Opioid Summit, let me hear you make some noise. You enjoyed the speaker so far? All right, awesome. Listen, you can't go anywhere in town and find free NBCC and NASW free CEU. So listen, we've had like $2 or $3 on it. We're about